Okay, so this is mostly not quite cases, but more of a spot diagnosis with nerves and muscles. There's so many signs you can see in the arm and or the leg, and you could diagnose somebody from looking at that. Unlike a lot of brain and spine, you still rely a lot on imaging. With nerves, you really rely almost 90% on your clinical exam, and then you can tweak it a little bit with an EMG or imaging, but you rely heavily on the exam. So I want you to be able to look at those and be able to diagnose. So the first thing I want you to look at is going to be the hand. And there are so many things you look at the hand and you would be able to diagnose. So let's start with Joyce. Are you there?
I'm here.
What's wrong with this hand?
The right hand, it looks like there might be some thenar atrophy. The pinch is not a circle. It's like more.
That's very good. You did pick up on the abnormal side, which is really important. Are you able to elaborate more? Like tell me which muscles are not working?
The thenar muscles of the thumb, maybe.
Why can't they pinch properly, Joyce? Look at the two hands and say, what's wrong with that pinch?
So it's not the tip of the fingers. It's the tip of the second finger on the. So the thumb cannot really curl, I think. I'm
So
not sure.
you're missing flexion of the distal phalanx of the
Yeah.
thumb and the
Yeah.
index finger. So you just need to go back to your anatomy and tell me which muscle slash tendon would flex the distal phalanx of those two fingers. Then we'll go to the nerve supply of those muscles.
I don't know.
Kelsey, can you help?
I think it's FDP.
Correct. So for the index finger, it is the lateral aspect of the FDP, which for Joyce, this stands for flexor digitorum profundus. But that muscle doesn't go to the thumb. What goes to the thumb?
Flexor hallucis longus.
Okay, hallucis is in the foot, pollicis is in the hand.
Sorry.
So FPL or flexor pollicis longus. So which nerve supplies those two muscles? What type of palsy is this?
Ulnar nerve.
Can you think about it again? Ulnar actually goes to the medial half of the profundus, not the lateral half.
Oh, so, median nerve then.
Okay, so what part of the median nerve?
Is it anterior interosseous branch?
Yeah, so that's a typical picture of the AIN palsy, anterior interosseous nerve, when they're unable to make the OK sign. So AIN allows you to make the OK sign. So when you look at this picture, that's screaming AIN palsy on the right side. Back to you, Joyce. What sensory loss you get with that? Still there, Joyce?
I don't think it has a sensation. ION is just a motor nerve.
Yes, it does not have a skin distribution, correct. It's okay if you say what you said, but a motor nerve carries some sensory proprioception, but it doesn't have any skin cutaneous distribution. So you're right. Good. So that's an AIN pulse. Okay. We are, I don't think we have any more residents, do we? So Joyce, we're still with you. What's wrong with this guy here?
He can't, so it's, I think, the left hand now.
Very good.
So the thumb and second finger, he can't flex the proximal maybe, and the middle phalanxes. I don't know. It's also he can't flex the middle and thumb, the second finger and the thumb.
Yeah, and you picked up very well that it's not just the distal phalanges like we saw in the previous case. It's more than that. So what muscles you think are involved here?
I have to review the muscles of the hands and arms. I don't really remember them. Sorry.
Niall, can you help? What's wrong with this picture here?
Sorry, I had some technical difficulty logging on here. I may have missed some of this.
No, there's nothing more than the picture.
Okay, so what we're seeing here.
Again, for people who just logged on, we're just doing like spot diagnosis. I want you to be able to tell from looking at the hand what nerve palsy we're dealing with.
Yeah, it looks like, I mean, this person's having inability to flex their first through third digits, almost like a hand of benediction in some way. So maybe like a median.
Oh, you go, Niall. Excellent. That's a benediction hand, although I'm showing you the hand on the side, but you have to imagine the Pope with this hand going this way when he blesses people. So that's a benediction hand. And it's, you said what nerve palsy is that?
So this is specifically an issue with the, it's median nerve, and it is, I forget, it's a median nerve issue, I believe.
Okay, in which location?
This is located, I think it's.
I mean, do you see this with carpal tunnel?
No, you do not. So this is.
Why not?
Because this is affecting the flexor digitorum profundus, I believe.
And
superficialis.
Correct. So what location of the median nerve is that?
So is that above the pronator teres?
Yeah, a high median nerve, whether in the around the elbow or distal arm, would give you that picture. And the sensory loss you get with that is going to involve both the fingers and the palm of the hand. If you have just carpal tunnel, you don't lose sensation in the palm because in most cases, the palmar cutaneous branch takes off higher than the wrist. So with the benediction hand, you can lose sensation in the palm, but not with carpal tunnel. Good. Lars, are you there?
Yes, I'm here.
What's wrong with this hand?
So yeah, the thenar eminence is wasting, so there's clearly some atrophy there.
Okay, when would you see that?
I think it's a more distal injury to the median nerve, like under the carpal tunnel, perhaps.
Very good. Yeah, so that's thenar atrophy that you're seeing here. And you could see that was very advanced carpal tunnel that went unfixed surgically. But unfortunately, you could see it also post-operatively with iatrogenic injury of the palmar recurrent branch that gives the motor supply to that thenar eminence. Good. I think Garrett is with us as well. Garrett, what's wrong with this hand?
Yeah, you want to mute your again, I see some atrophy of where the area of this snuff box would be, or I guess not where the snuff box would be, but looks to me like it would be the dorsal portion, like right in between your right on the dorsal aspect of where your thenar eminence would be. I think there'd be something wrong with your dorsal interossea.
Okay, very good. So that's the space for the FDI, or first dorsal interosseous muscle. Very good. What else do you see?
I don't know.
How about the other picture? The one with the hand on the side.
It looks like there's thenar atrophy as well.
Okay, very good. So what causes these two things?
I think there'd be possibly an ulnar nerve problem.
Okay, I'll give you that. Ulnar nerve would cause the hand that you're seeing, the FDI atrophy. How about the thenar atrophy?
That I would think median, but
So why would you lose both median and ulnar?
Something more proximal to where it,
at the level of what?
Blanket where what it would actually be. Maybe the inferior trunk of the brachial plexus, or
okay, lower trunk, and then more distally would be what? What happens after the trunks? You're doing good. Keep going. Keep going distally.
Yeah, I think, and from the trunks you enter the divisions of brachial plexus. It'd be maybe the lower division. Sure.
And how about after the divisions? What do you get after divisions?
I think you get chords from there. So.
Okay, so which chord would give you this picture?
Possibly the medial chord.
Very good. Okay, so the way you get median and ulnar together is either medial chord or lower trunk of the brachial plexus. Typical picture for a neurogenic thoracic outlet syndrome. And if you know the name of this hand, you can shout it out.
I can't remember honestly what the name is.
Oh yeah, I probably don't expect you to know. Brad, what's the name of this hand?
Ask that. I think it's isn't it like a French name? I can't remember the.
I don't know where he's from, but that's Gilead Sumner hand.
Yeah, it's some name. Yeah, sorry.
It's typical for neurogenic thoracic outlet. Okay. What else do we have here? Okay, how about we go back to you, Lars, on this one. Anything weird with this X-ray?
Yeah, there's a cervical rib.
Good. Yeah. So what you're seeing here, which side, right or left?
I did not know, just because Mark wants me.
Lars, what side is the cervical rib at? You're muted.
Oh, apologies. I thought I was unmuted. I think it's on that left side.
Yeah, it's probably going to be the call resonant, not positive.
Unless I'm flipping the image in my mind here.
Oh, Jesus.
No, it is on the left side. So
Okay.
Left C7, either a cervical rib or an elongated TP, which you could see in normal people, but you could also see in cases of thoracic outlet. And Here it is on the CT. You see it there on the left side. That's a cervical area. You could see that in a neurogenic thoracic outlet. Okay. Joyce, again, what's wrong with this hand?
The fifth digit and maybe fourth are flexed, they can't be extended.
Okay. Other than flexed, what else is wrong with that little finger?
Abductive?
Very good. So it's failing to adduct. It is abducted. So which muscle did you lose? You actually just described two different muscles. So there is one muscle that allows you to extend the interphalangeal joints. And there is another muscle that will adduct that little finger.
Adductus pollicis brevis is one. Maybe.
So pollicis is the thumb, right? So it's not going to do anything with the little finger.
I don't know.
Okay, Kelsey, can you help?
Yeah, so the muscles that would extend the interphalangeal joints, I believe, is the lumbricals, so the third and fourth
Okay.
lumbricals, and then it's the dorsal interossei that do adduction. Wait, or
So the palmar adducts.
oh,
So
yeah,
it's
palmar.
pad and dab. Pad,
Yeah.
palmar adducts, and dorsal abducts.
Mm-hmm.
Okay, what's the name of this hand
It's the
or the sign?
yeah, it's Wartenberg sign is the small finger sticking out, and I think it's a little bit of an ulnar claw hand as well.
So it's which nerve is not working?
Ulnar.
Okay, very good. So that's Wartenberg sign. You see that in ulnar nerve palsies. Okay. Lars, what's wrong with this?
So I think and I'm not entirely sure because it's kind of hard to orient here, but I think that what's wrong is that that left thumb that we're seeing on the right side isn't fully extended.
Yeah. So I must tell you here that you're putting the piece of paper in between the patient's first and second digits.
Oh, okay. So we're asking them to.
And you're asking him to hold it in place where you are pulling from the other side.
Got it. So actually the right side isn't able to flex. So that flexor digitorum or flexor pollicis brevis, I think, is responsible for that.
You're actually doing very well at the beginning.
Oh, I was? It's the left side that's wrong?
Left side is wrong. So on the right side, this is what you're supposed to do. You're supposed to hold it without having to flex your thumb.
Got it. Okay. So instead, he's not able to adduct his left thumb or her appropriately, and so is depending on the flexing. So I think it must be the adductor pollicis that's not functioning appropriately.
Okay, and which one is he actually using?
He's using his flexor digitorum or flexor pollicis. And I can't honestly recall whether it's brevis or longus.
It's the longest, yeah.
It's longest, okay.
Which nerve is paralyzed here?
Is it the is it one of the interosseous ones, or is there a? I thought there was a dedicated adductor for the thumb.
It is a dedicated muscle that, yeah, adductor pollicis, yeah. What supplies it?
So sorry, what was the question?
What's the nerve supply?
Oh, the nerve supply to the adductor pollicis. So it would be median.
No.
Ulnar then?
Yeah.
Okay, all right.
Yeah, so that's an ulnar nerve palsy, and as the ulnar nerve is paralyzed, he is using flexor pollicis longus, which is supplied by the AIN, which is a branch of what?
Of the ulnar nerve?
AIN, branch of what?
The median nerve?
Yeah. Yeah, the ulnar nerve is paralyzed, so he's using the AIN branch of the median nerve to hold the paper through the FPL.
Mm-hmm.
You understand that?
Yes, yeah, that makes sense.
Do you know the name of this sign?
I do. I didn't, but I do now. It's Prominence Sign.
Oh, who told you?
I won't tell.
Was that?
What's that?
You looked it up?
Yeah.
Okay, fair enough. So this is Prominence Sign on the left side here, and that's a sign of an ulnar nerve palsy. Good. Is Sarah Larson here or not attending? I don't see Sarah. Okay. We will go to Joyce. What's wrong with this hand?
So the fourth and fifth digits, it's like I think, did we see a similar picture earlier today or not yet? Looks like the Benedict's hand.
Okay, this is a common mistake. So let me spend a minute here. I think the people typically would tell you that you have to ask what the patient is trying to do.
Oh yeah. Might
With
be
the
the
Benedict sign, the patient is trying to make a fist and is unable to make a fist. That's the benediction sign. In this case, you're asking the patient to extend and the patient is unable to extend. And that's the difference between the two. So what's wrong with this one?
Yeah, he can't, the patient can't extend the fourth and fifth digits.
Okay. What is this a sign of?
You mean which nerve?
Sure, yeah.
I would want to say the ulnar.
Yeah, this is an ulnar claw hand. Okay. So with the benediction hand, the patient is trying to make a fist, but is unable to make a fist with the lateral fingers. With the ulnar claw hand, the patient is trying to open the hand and is unable to extend the medial two fingers.
Okay.
So people would tell you, you have to ask, what is the patient trying to do? I would tell you, look at the middle finger. If the middle finger is extended, they're trying to open the hand. If the middle finger is flexed, they're trying to make a fist. Okay?
Thanks.
This is an easy one for you, Lars.
So that looks to me, what is it? This patient's clearly trying to raise their hands up in front of them as if to say stop. And I think just a condition of the left hand that's not functioning.
Okay. And what's a nerve palsy here?
That looks like a radial nerve palsy or a C.
Yeah, that's a typical wrist drop for a radial nerve palsy.
Yeah.
Oops. I gave this away. So contrary to this one, on the right side, you could see the patient is trying to extend the wrist. But on the left side, the extension is complete and central. On the right side, instead of going like this, there is radial deviation this way. So the radial deviation, you see it was just a PIN palsy. It's not a complete radial nerve. And the reason is the extensor carpi radialis and extensor carpi ulnaris take off from the radial nerve proper. So the radial extensors are working. The ulnar extensor are not working because they take off from the PIN, the posterior interosseous nerve. So when you get a complete radial nerve pulse, you get the complete wrist drop. When you get just a PIN, your ulnar extensors are not working, but your radial extensors are working. So you get some wrist extension with radial deviation, okay? So that's PIN, it's a branch of the radial nerve. Okay. Garrett, what's wrong with this one?
It's pretty similar to one we just had, the ulnar claw.
Good. Kelsey?
Wartenberg sign again?
Good. What nerve palsy is it?
Ulnar.
Yes. Okay. Joyce, what's this one?
Oh, it starts with an F.
Okay. Prominence sign. So
Yeah.
which hand is the abnormal one?
The left.
So the left hand of the patient or the one on your left hand?
No, it's the right hand of the patient.
Sorry, the right hand of the patient or the left hand of the patient?
The right hand of the patient.
Good. So the patient's right hand has a positive prominence sign. And what nerve palsy is this?
This was the I'm not sure.
Do you remember which muscle is not working?
It was the pollicis longus, the flexor, the extensor, pollicis longus. I don't know. I wasn't paying attention at this. Sorry.
Yeah, you should pay attention. Kelsey, can you help?
Yeah, so it's the adductor pollicis that is not working. So it's again the ulnar nerve.
Okay, thank you. Okay, let's do a little bit on the shoulder. Lars, are you there?
Yeah, I'm here.
What's wrong with this?
So this looks like a wing scapula
What side?
on the right side.
Okay, what gives you that?
I think this is an injury to the long thoracic nerve,
Or?
or to the muscle itself, you mean, or a different nerve?
Yeah, there are 3 nerves and consequently 3 muscles that could give you that.
Okay.
It's okay to ask Niall for
Yeah, I'm not sure. I'd poll the audience, I think.
Niall.
I can name one other. I think the dorsal scapular nerve can also cause wing scapula.
Good. What else?
I don't know a third.
Garrett?
I'm not sure either.
Okay, who's going to tell us 3 of them? Kelsey, back to you.
And the spinal accessory nerve to it?
Yeah.
Yes, so what are the 3?
So the 3 are spinal accessory, long thoracic, and dorsal scapular.
Thank you. Okay, Joyce, can you try this one?
There's atrophy of the left, I think. I think I see atrophy on the left of the patient. I'm not.
Very good, very good. So what is prominent there? What's that big prominent?
That's the scapular head.
Well, scapula doesn't have a head. It's the spine of the scapula.
Yeah, spine of the scapula.
Okay, the reason it's prominent because the muscle above it and the muscle below it are atrophied, as you just said. Could you name those muscles?
I would say maybe the trapezius.
Just translate what I said into Latin. I said the one above the spine and the one below the spine.
The suprascapular.
Supraspinatus.
Spinatus and the infraspinatus muscle.
Okay, what's the nerve supply for those?
There's the suprascapular.
Yep, suprascapular nerve. So that's a picture of suprascapular nerve palsy or entrapment at the notch that gives you atrophy of the supraspinatus and infraspinatus. And because those two are atrophied, you're seeing the spine of the scapula. Lots of people mistake this for a winged scapula. It's a completely different picture. A winged scapula, there is prominence of the medial border of the scapula. But with a suprascapular nerve palsy, you have prominence of the spine of the scapula, not the medial border of the scapula. It's completely different. Okay. Okay, how about looking at the eyes? Lars, what's going on here?
Yeah, so that right eye looks like there's some ptosis. What is the patient trying to do? Are they trying to look straight at me?
Nothing. A patient is just looking at you in the office.
This is the face I'm seeing. Okay.
Yeah.
I seem mostly conjugate. It's a little hard to tell. There might be a little bit of down and out in that left eye, if anything.
Okay, tell me about the pupil size.
Pupil size is approximately equal. If anything, the patient's left eye is a little bit larger pupil, if anything. But otherwise, it looks pretty much equal.
Okay, tell me about the size of opening of the eye.
Slightly larger on the left, slightly less on the right.
Okay, does that tell you something?
Yeah, it could be a Horner syndrome.
On what side?
On the left.
Your left or the patient's left?
On my left, the patient's right.
Patient's right eye. So a patient has a right-sided Horner syndrome. Okay, you have ptosis and meiosis on the right side.
Mm-hmm.
And that's the first thing you want to look at in a brachial plexus clinic. And Garrett, what's the significance of this in the setting of a brachial plexus injury?
I know that there's a difficulty or a deficit, I should say, with the ascending sympathetic chain. It could be like a tumor or some type of lesion caused.
You're seeing someone with a flail arm. Trauma consulted you on somebody with a flail arm. Doesn't move anything in the arm in the setting of a severe motorcycle accident. That's the usual context of this. So you're not dealing with tumor, you're dealing with trauma.
Sorry, what's the question?
In the setting of the trauma, what's the significance of a Horner syndrome?
There could be some type of fracture causing the deficit to the ascending portion of the sympathetic chain. And maybe a clavicle fracture or something.
No.
I think given the tract of the sympathetic nerves, they'd be concerned for a carotid dissection, maybe, because you can hit the sympathetic plexus as it runs superiorly along the carotid.
Kelsey?
Oh, that was actually my thought as well, to make sure you're not missing a carotid dissection.
Brad?
Yeah, if you avulse C8T1, you're at, I think, particularly risk for sympathetic chain disruption as well.
Yeah, so you guys are thinking carotid or thinking the tracts in the spinal cord itself, which are good differentials. But in terms of brachial plexus injury, it's a sign of brachial plexus avulsion, because you get involvement of your superior cervical the stellate ganglion, and that gives you the Horner syndrome on the right side. And that's important in a trauma because if you're going to plan a surgery at some point, you want to know if the nerve roots are avulsed from the spinal cord or they're just stretched in the axilla or the supraclavicular area, in which case you can have something to graft from, right? If you have an avulsion, then you have to resort to nerve transfers and other things. And this is a typical MRI that you would see in this scenario where you have the Mickey Mouse ear here with a pseudomeningocele on the right side. And that's what we look for in when you're examining a brachial plexus trauma. The first thing you look at is the eye, not the arm. Okay. Next. Okay, how about some easy sensory syndromes for the lower extremity? Let's do some of those. Joyce, tell me, this patient had open heart surgery. They harvested the saphenous vein. He has pain, numbness, and tingling in that distribution you're seeing here. And he has a Tinel sign here. So what nerve distribution is this, and what do you think happened? Joyce, are you there? You're still muted.
Oh, I'm sorry. I'm still in clinic and Dr. Brooks was talking to me. Sorry. Can you repeat the question?
Oh, someone had open heart surgery. They have wristed saphenous vein, and he has pain and numbness in that distribution.
Okay.
So what do you think happened? What nerve distribution is that?
Superficial femoral?
Superficial femoral. It's a branch from the femoral nerve, you're right, but it's not called superficial femoral.
Oh, it's the cutaneous. What's it called? I'm not sure. I don't remember.
Garrett, can you help?
Saphenous nerve.
So saphenous nerve, very good. Yeah, it runs with the long saphenous vein, so they carry the same name. And it got injured in this location here with a scar. Saphenous nerve can also be involved in pain after knee replacement. There is an infrapatellar branch that, if it gets injured during knee replacement, could be a cause of chronic knee pain until someone does something with it. Lars, what is this? Patient complains of burning pain and numbness in that.
Yeah, that's excuse me. Garrett needed to mute there. That's the lateral femoral cutaneous nerve distribution.
And what's the name of the syndrome?
Neuralgia paresthetica.
Who is whispering in your ear? That's fine. That's correct. Neuralgia peristhetica.
I think it has a lot of other names, though. I was reading somewhere that there were like 5 or 6 other names for this at one point.
Maybe.
But we'll go with neuralgia peristhetica.
The one that has multiple names I know is Parsons-Turner. If you know 5 other names for this, please, yeah, let me know. Send me an email or something. Okay. Joyce, are you still with us, or you're in clinic?
I'm here.
Okay, tell me, the patient has pain and numbness in that distribution. Which nerve distribution is that?
I don't know.
We have, who else can help here? Niall.
This is in the distribution of the peroneal nerve.
Okay, that's good. And if you see there's sparing of the first web space, the dorsal aspect, can you tell me which part of the peroneal nerve then is involved?
I think the superficial, because the deep runs more distally.
That's very correct. That's the distribution of the superficial peroneal, and dorsum of the first web space, that is the part supplied by the deep peroneal nerve. Okay, and Garrett, patient had ankle surgery. She has chronic pain, numbness, and decreased sensation in that distribution. She has a Tinel sign where you see that X mark.
I think maybe the sural nerve could be damaged here.
Good, good. That's the trajectory, that incision is right on the trajectory of the sural nerve. That's where we do our incision. We probably go a little high. When we're trying to do a nerve biopsy, we go up high there, or when we're harvesting the sural nerve for nerve grafting, we go up high there. Okay. I think I'm going to stop here. This is a lot of material that we went through. Lecture is going to be recorded so you guys can review those signs again. I don't want to cram your brain with more cases and stuff. If you retain the material we went through, that would be great, and it would solve a lot of cases for you, whether it's on the test or in real life in clinic. You really need to pick up on those signs, because again, if it's a nerve problem, there's mainly a clinical diagnosis, and very little you can add on from the EMG and imaging. But unless you have a very good clinical background, you won't even be able to interpret your EMG. Most of the EMG conclusions, guess what, are going to tell you clinical correlation is important. So it's going to come back at you to rely on your clinical exam. Questions? All right. Thanks, guys.
Thank you, Dr. Hanna.
Thanks, Dr. Hanna.
Thank you.
Thanks.
Thank you.